Very good evening and welcome to one and all. I am Momita from Clarinet, the designated session assistant for a seamless experience. And Clarinet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clarinet is very proud to be a digital partner for this event organized by Society of Onco Anesthesia and Perioperative Care. And the topic of today's session is neutropenic sepsis. So let's begin today's session, for which I would like to invite Dr. Jyotsna Goswami ma'am to take over. Over to you, ma'am. Thank you.
Thank you, Mamita. So, good evening and welcome you all to this session. This is the SOPSI E-Education Lecture Series 40. And as Mamita says, today's topic is neutropenic sepsis. And I will invite today's chairperson, Dr. Sudipta Mukherjee, who is consultant and head Department of Critical Care Medicine, Tata Medical Center, Kolkata. Over to Dr. Sudipta, please. Dr. Sudipta, please.
Yeah. Good evening, everybody. Thank you, ma'am, for your kind words. And thank you, Sopsi, and we, in terms with collaboration with Learnet to organize such an important topic for our regular discussion, which is neutropenic sepsis. I think people who are working in oncology setup have to deal with neutropenic sepsis on a regular basis, and it is probably one of the worst kind of sepsis because patient's own immune response is not there, and whatever the infection is entering the bodies to the bloodstream of the patient, most of the time those are already colonized in the patient's body. So even if you take all the precautionary measures to prevent it, patient bacteria may transmigrate from the bowel, from the skin, from the nasal mucosa, and patient can develop sepsis because of poor immunity. So today we have to talk about on this topic. We have Dr. Deepa Chandramohan. Madam is a senior consultant and head of the Department of Critical Care Medicine of MBR Cancer Institute and Research Institute, Kozhikode. She has also worked in Government Medical College, Goa, and Narayana Health Hospital of Bangalore. She has multiple publications, and because presently she is working in oncology setup, and I think that one of the areas of interest are neutropenic sepsis and CRS HIPEC like post-operative management. So welcome, ma'am, and over to you.
Are the slides visible?
Yes, ma'am, visible.
Okay. Good evening, everyone. Thank you, Dr. Sudipta, for the kind introduction. I would like to take this opportunity to thank all the stalwarts of SOPSI, especially Dr. Goswami, Dr. Anjali, Dr. Solanki, Dr. Garg, and all other important members of SOPSI for giving me this opportunity to be a part of this Thursday evening academic feast of SOPSI. So, greetings from my institute, MBR Cancer Center and Research Institute, Kozhikode. So the topic for today is neutropenic sepsis, which is a slight deviation from the usual topics that have been discussed in all these Thursday evening topics. So before I move on to the discussion per se about neutropenic sepsis, I would just like to share just short case presentations about two cases who presented with neutropenic sepsis. So the first case was a 34-year-old gentleman with acute myeloid leukemia who received his chemotherapy with cytarabine and daunorubicin, his induction chemotherapy, and the following are the events which happened after that. By day 3, he had an absolute neutrophil count of 60. And the patient was in the medical oncology ward, and he was started on prophylactic oral voriconazole and acyclovir as per the medical oncology protocol. By day 8, the absolute neutrophil count dropped to 0. So that means absolutely nil, and the patient developed tachycardia, following which they started the patient on antibiotics, higher antibiotics of piperacillin, tazobactam, and amikacin. By day 11, he presented with fever, loose stools, and there was a perianal abscess as well. The blood culture panel, or the rapid test or nucleic acid amplification test, gave the diagnosis of growth of ESBL, or drug-resistant Klebsiella pneumonia and Candida in blood. The CT thorax showed invasive pulmonary aspergillosis, and CT abdomen was suggestive of neutropenic colitis. Again, the antibiotics were high to meropenem, colistin, teicoplanin. Antifungals like caspofungin and voriconazole were added. Then PICC line was removed, through which he was receiving chemo, and the patient was started on high flow nasal oxygen. By day 12, again, the patient had persistent fever, loose stools, but a new symptom, that's convulsions. His GCS was E3M6V5, no focal neurological deficit or signs of meningeal irritation. The stool CD toxin or Clostridium difficile toxin was positive, and a CT brain showed a left cerebellar abscess kind of a lesion. Again, oral vancomycin was added. The antibiotics and antifungals were continued. By day 13, the blood culture reports were ready that showed an extensively drug-resistant Klebsiella, and the MRI brain showed fungal abscess and subcutaneous or subcutaneous hematoma, which was a differential diagnosis, but clinically it was more in favor of fungal abscess. So again, the antibiotics had to be hiked into aztreonam, ceftazidime, and avibactam, the highest possible antibiotics which we have. We got a neurosurgery consultation also done, but then they mentioned to go ahead with conservative management. And by day 18, the absolute neutrophil count improved to 800, and patient was transferred to the ward. Luckily, this patient did not go into septic shock. So that was about the first case. This was the CT thorax of the patient with the peripheral lesion on the right lung, which was suggestive of aspergillosis. And this was the MRI brain, which showed cerebellar fungal abscess. So next is about a 66-year-old lady. This is a case report which I found it to be interesting. This was published in 2020 in the Journal of Case Reports on Oncological Medicine. So this was a 66-year-old lady with a relapsed CA ovary who received chemo with carboplatin, gemcitabine, and bevacizumab. By day 14, she presented to the emergency department. She received chemo and she was fine. She went back to her home. And on day 14, she presents in the ED with fever, nausea, watery diarrhea. There was no abdominal pain. When the investigations were done, WBC count was 400 and platelet count was 10,000 per microliter. She was admitted in the ward, given blood transfusions. They started with granulocyte colony stimulating factor, GCSF, and they started the antibiotics, cefoperazone and sulbactam. By day 17, that's within 3 days, she developed severe acute abdominal pain. On examination, she had severe tenderness and rebound tenderness. And CT abdomen showed bowel wall thickening with a GI perforation. So an emergency laparotomy had to be done, which showed peritoneal spillage as well as dissemination of the cancer. And also the findings were suggestive of neutropenic enterocolitis. By day 19, she was post-operatively, she was shifted to the surgical ICU. By day 19, she developed again an intra-abdominal abscess and went into septic shock. So she was started on higher antibiotics. A CT-guided pigtail insertion was done. Colistin was also added. Patient went on mechanical ventilation. And by day 56, so that many days had passed, the ANC, or the absolute neutrophil count, recovered to more than 1,000. She recovered and she was discharged. So this is just to give you an idea of how bad neutropenic sepsis can be. So the earlier case was a typical medical oncology ICU case, and this second case would be like a surgical oncology case, and this is one of the scenarios which an onco anesthesiologist would usually encounter. So this is the CT abdomen of the same lady, which shows pneumoperitoneum and also thickened bowel wall. So now let's move into the discussion part of neutropenic sepsis. So since it's an elaborate topic, I've just cut it into multiple subtopics like the definition, the problem, the risk factors, the sources of sepsis and neutropenic sepsis, the pathophysiology, the diagnosis and management of neutropenic sepsis. So neutropenia is defined as an absolute neutrophil count of less than 1500 per microliter. You call it severe neutropenia if the ANC is less than 500 and profound neutropenia if the ANC is less than 100. Prolonged neutropenia is when the neutropenia lasts for more than 7 days. So there is a high risk of clinically important infection or sepsis in those patients who have severe as well as prolonged neutropenia. Now the definition of febrile neutropenia. This is for theory purposes. It's like an oral temperature of more than 100.9 degree Fahrenheit or 2 consecutive readings of more than 100.4 degree Fahrenheit for 2 hours and an absolute neutrophil count of less than 500 or the ANC is expected to fall below 500 within the next 48 hours. So that is when we call it febrile neutropenia. And now coming to the definition of sepsis, the latest definition of sepsis is that it's a life-threatening organ dysfunction caused by a dysregulated host response to infection. A simpler definition would be the earlier ones where it says that sepsis is nothing but infection in the body. Along with that, there should be systemic inflammatory response syndrome or SIRS. Along with that, there should be evidence of organ dysfunction. If this is associated with hypotension, then you can call it septic shock. So if these two coexist in a same patient, that is a febrile neutropenic patient with sepsis, and then that condition is called neutropenic sepsis. So that's about the definition. So where do the onco-anesthesiologists and onco-intensive care physicians usually encounter these kind of cases? In the medical oncology ICU, it's usually the post-chemotherapy. The patient comes with neutropenic sepsis and its related complications like sepsis and septic shock. Another scenario would be like similar to the second case which I presented. The patient could go into neutropenic enterocolitis and then result in perforation peritonitis and can present in the emergency department, or you may directly see the patient in the operation theater. So you have intra-op complications also, and then post-operatively, most of the time you will have to shift the patient to surgical ICU, where again you will be taking care of these patients. And the third scenario will be that similar kind of a case when they present in an unstable state in the emergency department. The surgical oncology team may want to shift the patient to the ICU first for a preoperative stabilization, like they would want the hypotension or the hemodynamic management to be done, the thrombocytopenia to be corrected and all before taking up the patient for interventions. So these are the three usual encounters that an onco-anesthesiologist faces. So what is the burden of the problem of neutropenic sepsis? So sepsis is a leading cause of death in neutropenic cancer patients in ICUs. The incidence of febrile neutropenia in solid tumors is 5 to 30%. It's even more, like 80% in those with hematological malignancies and hematopoietic stem cell transplant patients. The incidence of sepsis and septic shock in a febrile neutropenic patient is usually, it ranges from 7 to 45% as per the literature. But though this is a high incidence, the detected bacteremia in a febrile neutropenic patient is only 20%. That means the cultures turn out to be positive only in 20% of the patients. And the mortality rate in neutropenic sepsis is pretty high. It is 70% if no antibiotics, and with antibiotics also it comes to 4 to 20%. The overall in-hospital mortality comes to about 10%. And the mortality is even higher if the patient has multiple comorbidities, if they have a bacteremia which is caused by gram-negative rods, and also if they have tissue invasive infections such as pneumonia or even brain abscess. So what are the risk factors for sepsis and septic shock in a patient who already has neutropenia? So patients with hematological malignancies or post-stem cell transplant and prolonged neutropenia, those with refractory or advanced disease, tumors that invade lumens, tumors that invade contaminated sites, a prolonged hospital stay, prior surgery, post-intense chemotherapy, patients with indwelling vascular catheters or stents or percutaneous nephrostomy tubes, pneumonia, hypophosphatemia, hypoproteinemia, corticosteroid use, recent and frequent hospitalization, and mask score of less than 21. So these are risk factors for sepsis and septic shock in neutropenia. MAS score is just a risk index score that the oncologists usually use to predict the occurrence of complications in a neutropenic patients. It's just the abbreviation of Multinational Association for Supportive Care in Cancer. So it takes into consideration the age, the comorbidities, the various symptoms, and the kind of tumor. And a MAS score of more than 21 means it's predictive of low risk febrile neutropenia. So why do we need to know these risk factors? That's because when we encountered with a febrile neutropenic patient, you need to assess the risk to decide whether what kind of treatment the patient should get. If it's low risk, like solid tumor and anticipated neutropenia of less than 7 days, hemodynamically stable patient, then they need only outpatient management and follow-up. And we do not get to deal with these kind of cases. But if the MAS score is less than 21, patient is a hematological malignancy or post-stem cell transplant, severe neutropenia, and anticipated prolonged neutropenia, these are considered high risk. And these patients require inpatient management and early ICU admission. Early ICU admission means the patient has started having physiological disturbances, but they have not started going into any sort of organ dysfunction. So it's kind of a prophylactic ICU admission. And these are the cases which we get to deal with. So what are the sources of infection in sepsis? The usual sources of infection would be bloodstream infections. It can be a central line associated bloodstream infection or CLABSI, or a mucosal barrier injury related bloodstream infection, because most of the time the mucosal barriers are lost, especially of the gastrointestinal tract. And then gram-negative Enterobacteriaceae, they get into the bloodstream, and that can cause a bloodstream infection. So majority of the cases, they say, though they are branded as central line associated bloodstream infections, they are mostly or most probably mucosal barrier injury related laboratory confirmed BSIs. The next is respiratory infections, pneumonias caused by bacteria as well as viruses and fungi. Gastrointestinal infections, maybe infections in solid tumors like cholangitis or some abscesses. Then it could be hepatosplenic candidiasis or even neutropenic enterocolitis, Clostridium difficile associated diarrhea, or other infective diarrhea caused by bacteria or viruses. And central nervous system infections like meningitis, meningoencephalitis, and also focal brain lesions such as abscesses. Urinary tract infections, mostly they are infections due to urinary diversions, and it can also be due to the presence of infected stents and percutaneous nephrostomy tubes. And skin and soft tissue infections, most common which we see is the perianal abscess. The patient develops diarrhea and then develops a perianal abscess, and that small thing is the source of sepsis in these patients. So that's about the sources of infection. And what about the microbiology? The usual organisms or the microbes are the bacteria, fungi, viruses, and parasites. The bacteria, usually we use a mnemonic of escapes, that is Enterococcus and Staphylococcus, which are gram-positive bacteria. Then all the GI associated gram-negative bugs, namely Klebsiella, Acinetobacter, Pseudomonas, Enterobacter, and also Stenotrophomonas and Clostridium difficile. That's also quite common. Fungi, the yeasts, namely Candida. Candida species are mainly involved, and invasive mold infections are caused by Aspergillus mucos species and Pneumocystis carinii, renamed as Pneumocystis jirovecii. And viruses usually are adenovirus, the SARS-CoV-2, norovirus, which can cause diarrhea, and CMV, which is more common in post-stem cell transplantation. Parasites, it's usually only Strongyloides stercoralis, which is most commonly seen. So that's about the microbiology. Now coming to the pathophysiology, it was always believed that neutrophils and the inflammatory mediators released by the neutrophils are the main culprits in the pathogenesis of sepsis. But our patients do not have neutrophils at all. They usually come with an ANC of 0. So then how does sepsis happen in these patients? So it's quite difficult to describe, or the studies are still going on even at the molecular level about the pathophysiology of sepsis. So it's postulated that probably there are a lot of pro-inflammatory and anti-inflammatory mechanisms involved. And we already defined sepsis as a dysregulated host response to infection. But sepsis is a more complex immunological response. But nevertheless, no significant pathophysiological differences have been noted between neutropenic and non-neutropenic sepsis patients. The pathophysiological problems and the disturbances which happen in the body in both these kinds of patients are the same. But we have always observed a rapid worsening and higher mortality in patients with neutropenic sepsis. And because of the same reason, a prompt diagnosis and timely initiation of management is important, because sometimes you have to start your management right in the operating room itself, so that the patient is a bit stabilized, at least by the time the patient reaches the post-op unit. So now we have discussed about the initial part. We'll move on to the diagnosis and management. So since the pathophysiological differences between neutropenic and non-neutropenic patients are almost the same, the guidelines that we usually follow are the Surviving Sepsis Campaign, or the SSC guidelines, which have been published in 2021. I've also consulted the 2018 guidelines, which has been issued by the German Society of Hematology and Medical Oncology, and this has been published in 2019. I've also taken into consideration the clinical practice guidelines by the ESMO, the central venous catheter related infection guidelines by the German Society, again published in 2020, and also the 2023 update on sepsis and septic shock in the emergency department, published in the Journal of Clinical Medicine. So I've gone through all this and compiled the best out of it. So the diagnosis of sepsis is tricky. Mainly because in neutropenic patients, because neutropenic patients usually have attenuated signs and symptoms of infection, unlike the general population. And more than 1/3 of these patients who were initially diagnosed to be sepsis turn out to have non-infectious causes, which are otherwise known as sepsis mimics. And also, the most important thing is there is no gold standard diagnostic test for sepsis. So that's why we say the diagnosis of sepsis is tricky. So you should have a high index of suspicion in acutely ill and high-risk patients. So we know how to risk stratify the patients. And when they turn acutely ill, you should have a high index of suspicion for sepsis. And we should use screening tools such as early warning scoring systems like the modified or the national or the SIRS criteria. The sepsis campaign guidelines, they no more recommend Q-SOFA or the SOFA. And one of the main reasons you cannot use this even in oncology patients is that SOFA score takes into consideration of factors like thrombocytopenia. Your neutropenic patient is already will be having thrombocytopenia as a part of the disease process and post-chemo. So you cannot consider it as a part of sepsis. Also, the increased bilirubin levels and creatinine levels may happen because of the effects of chemotherapeutic drugs. Even the GCS, which is a part of the SOFA scoring system, or the Q-SOFA, it could be due to multiple reasons. It may not be due to sepsis always. Maybe because of the disease progression into the CNS, and also there are multiple electrolyte abnormalities like hyponatremia, which can happen in oncological patients. And these early warning scoring systems would be better, but still we don't have a perfect scoring system or a perfect screening tool. Important point to remember here is that these are all just screening tools. They are not diagnostic tools. So how do we diagnose sepsis then? So first of all, you have to go into the history and physical examination. History, we definitely know this is an oncological patient, either a solid organ or a hematological malignancy or a post-stem cell transplant. And then you do a thorough physical examination with special emphasis for catheter sites, especially the intravascular catheter sites, then the skin and the perianal region. These are 3 sites which you should never forget to examine. Then we can have clinical symptoms and signs like fever, tachycardia, tachypnea, hypotension, altered mental status, acute oliguria, ileus, and oxygen desaturation. You can also have adjunctive tests and laboratory data. Again, I'm repeating it, these are not diagnostic tests. So if your patient has a raised serum procalcitonin in a patient whom you are suspecting sepsis, you feel that there is a high likelihood of sepsis in this patient, and you find raised serum procalcitonin in these patients, then your diagnosis is moving more in favor of sepsis. And raised serum lactate, if you find serum lactate elevated in a patient in whom you are suspecting sepsis, yes, then again your balance tips more in favor of your diagnosis of sepsis. There can be drop in PF ratio, so the PaO2 by FiO2 ratios, rising serum creatinine, altered LFTs, and coagulopathy. So history, physical examination, the clinical symptoms and signs, and the adjunctive tests and laboratory data. And specific investigations which you send for sepsis would be an imaging of the chest, abdomen, pelvis, and brain. Rather than an X-ray of the chest, a CT would be the best. Blood cultures, 2 sets you have to send. Cultures from relevant sites after your physical examination, a stool sample for Clostridium difficile toxin, lumbar puncture in case of CNS issues, a bronchoscopy and a BAL sample, and NATs or nucleic acid amplification tests. For example, it's the biofire sepsis panel and pneumonia panel where you send the sample, and suppose it's respiratory secretions which you've sent for a pneumonia panel. Within 1 hour, they'll identify the bacteria and let you know. In addition to that, they will also give you what are the antimicrobial resistance genes which are present in that particular bacteria, so that you can modify your antibiotic. You will not get the culture sensitivity report at that time. At least they'll be able to identify the bacteria, the microbe, the virus or the bacteria or the fungi, and let you know. Along with this, the relevant investigations for sepsis mimics or non-infectious causes also should be sent. For this, we should be knowing what are the sepsis mimics. So the sepsis mimics or conditions which can mimic sepsis will include acute pancreatitis, anaphylaxis to drugs, diabetic ketoacidosis, drug withdrawal states, adrenal insufficiency, cytokine release syndrome following CAR T cell therapy, neural malignant syndrome. So you can rule out all these using your history and physical examination and the clinical features, and also from specific investigations which you can send to rule out these. So the diagnosis of sepsis will depend on history and physical examination, clinical symptoms and signs, adjunctive tests and laboratory data, along with the most important thing is suspicion of infection or proof of infection. So that is how you diagnose sepsis. So now we'll go to the management of sepsis and septic shock. So once you recognize the condition, your clock starts ticking. So you start with antimicrobials immediately, ideally within 1 hour, then initial fluid resuscitation, which should be completed within 3 hours, admission to ICU, preferably within 6 hours, do the source control or find out what is the infective source and get rid of that, preferably within 6 to 12 hours. Then you should continue with your continued hemodynamic management with vasopressors, inotropes, and fluids, ventilation, and additional therapy. So these are the topics which we'll be discussing under management, namely hemodynamic resuscitation, antimicrobial therapy, and source control. The first 3 are very, very important, and then ventilation and additional therapies. So we'll move on. So in hemodynamic resuscitation, we have components like initial fluid resuscitation, continued fluid resuscitation, vasopressors, inotropes, and monitoring. So fluid resuscitation should be given only if patient presents with signs of hypoperfusion. So in septic shock, obviously you have to give, but when a patient comes with just sepsis, look for signs of hypoperfusion like tachycardia and capillary refill delay, or you will have tissue hypoperfusion investigation parameters like increased serum lactate. So these are various signs of hypoperfusion, also cold and clammy extremities. So the initial fluid resuscitation, what fluid which we use is balanced crystalloids. It's not no more normal saline or ringer lactate. They prefer to use balanced crystalloids. Starches and gelatins are not recommended. And so the initial fluid resuscitation, at least 30 ml per kg of fluid should be given, and that process should be complete within 3 hours. And you can use dynamic measures like the fluid responsiveness to a passive leg raise or a fluid bolus using stroke volume or stroke volume variation and echocardiography or PPV, whatever is available with you. And you can use serum lactate as a guide because that gives you an idea about tissue perfusion. The capillary refill time can be checked, and also you can keep checking the mean arterial pressure also. But the more important parameters to look for are the dynamic measures, lactate, and capillary refill time. In spite of initial fluid resuscitation, again, the patient will require continued fluid administration during the first 48 to 72 hours. Again, here balanced crystalloids are the advocated fluids. Albumin in patients may be used or can be used when you have already used large volumes of crystalloids in patients. Again, for continued fluid administration, they advocate dynamic measures rather than going for static hemodynamic parameters. So if you are unable to achieve a good mean arterial pressure, or your signs of hypoperfusion are not improving, then you need to go with vasopressors. And the first line vasopressor of choice is noradrenaline. So when you're using vasopressors, you should target a mean arterial pressure of at least 65 millimeters of mercury. There is no need to attain supranormal levels of MAP, but a mean arterial pressure of 65 millimeters of mercury is more than adequate. And if noradrenaline requirement is going up like 0.25 to 0.5 mics per kg per minute, when it reaches that level, you're supposed to start the second line drug, which is vasopressin. So vasopressin, unlike adrenaline and noradrenaline, it's not a titrated drug. The usual dose uses 0.03 units per minute. Many RCTs have used up to 0.06 units per minute. So I believe that is the maximum dose that is advocated for the time being. And the third line drug, if both NORAD and vasopressin are on flow and you're not able to achieve a MAP of 65, then you use adrenaline infusion. Next is about inotropes. When do we use inotropes? Suppose the patient has cardiac dysfunction and that causes persistent hyperperfusion despite you attaining a good fluid status. In such, and a good arterial pressure. Your arterial pressure is normal, but you are seeing that your extremities are still cold and clammy, your lactates are not coming down, and your capillary refill time is also delayed. And in such cases, you have to use inotropes. The drugs that I use are dobutamine and adrenaline. So you can add dobutamine to noradrenaline, or you should be replacing noradrenaline with adrenaline. In patients who have received doxorubicin, daunorubicin, etc., they are notorious for causing cardiotoxicity. So in such cases, an early screening to look for cardiac dysfunction is advisable. And in the monitoring part, an invasive arterial blood pressure monitoring is preferred over non-invasive blood pressure monitoring. So that's about hemodynamic resuscitation. Now about intravenous access. To resuscitate your patient with IV fluids, 2 wide-bore peripheral lines are more than enough. But when you have to start vasopressors, a central venous line is always preferred. But mostly we have problems like thrombocytopenia or coagulopathy when we are about to start, get ready for the central line. So you need to correct that. But do we have to delay starting vasopressors just because a central venous line is not available? No, you can start actually vasopressors through a peripheral IV line, provided that vein is in the antecubital fossa or in a vein which is proximal to the antecubital fossa. And the duration for which you can administer vasopressors through a peripheral line is maximum 6 hours. Within that, you should be ready by, transfusing the platelets or FFPs or cryos and then getting a central venous line in situ. Some authors also recommend early initiation of noradrenaline at a dose of like 0.1 to 1.2 mics per kg per minute within the first hour, if fluid infusion alone is not sufficient to reach the desired MAP. I mentioned that the initial fluid resuscitation happens in the first 3 hours. But some authors mention that it's better to start noradrenaline at a lower dose within the first hour itself, because a delay in vasopressor initiation and a delay in achieving a mean arterial pressure of 65 mm mercury is associated with increased mortality. But the SSC guidelines have not yet put forth anything of that sort, so we'll have to probably wait regarding that. And celepressin and angiotensin 2 are 2 vasopressors in which ongoing studies are going on. They seem to be promising, but we need more evidence to include them in the SSC guidelines. So now when the continued fluid, after the initial fluid resuscitation, you'll have to continue with your fluid resuscitation. The question is whether you should use a restrictive fluid strategy or a liberal fluid strategy in the first 24 hours of resuscitation if the patient has persistent signs of hyperperfusion and volume depletion despite initial resuscitation. So neither restrictive nor liberal has found to be associated with an improved outcome. So the consensus is that you go for an individualized fluid management. You rely on dynamic parameters, perfusion parameters like lactate and capillary refill time, hemodynamic variables like mean arterial pressure and the static hemodynamic parameters, and also physical examination. So you combine all these and go for an individualized fluid management, especially in the first 24 hours. In our institute, we usually use for all septic shock patients, we use the non-invasive cardiac output monitor that gives you a fluid responsiveness in response to a fluid bolus or a passive leg raise using a bioreactance technique. So that's about hemodynamic management. Your next step should be intravenous antimicrobial therapy. So there are two kinds of patients. One is those in which shock is present, or those patients in which sepsis is a definite or probable diagnosis. In these patients, if the patient is in shock, irrespective of you being sure of sepsis or sepsis being one of your diagnosis, administer antimicrobials immediately. Ideally, you're supposed to administer within 1 hour of recognition. And you should obtain microbiological samples for culture prior to administration of antimicrobials. Now, the second set of patients is patients in whom there is no shock and sepsis is one of the possibilities. You want to rule out other sepsis mimics also. In such patients, a rapid assessment of infectious and non-infectious causes is required, which should be complete within 3 hours. And still at the end of 3 hours, if you feel that there is a concern for infection, then you start antimicrobials, and that too within that 3 hours time frame. So that's about antimicrobial initiation. Now, obviously, these patients will be started on empirical antimicrobial therapy because these patients are neutropenic sepsis oncology patients are at high risk for multi-drug resistant organisms, MRSA, Candida species, and Candida sepsis and invasive mold infections. So what is recommended is to start 2 antimicrobials with gram-negative coverage in patients with septic shock, together with that antimicrobials with MRSA coverage if the patient is high risk for MRSA. And if the patient is at risk for fungal infections, then you can think about adding antifungals against Candida species and molds. These patients who are febrile despite 4 to 7 days of broad spectrum antibacterial therapy, they are also at increased risk of having fungal disease. So despite giving antibacterials for more than a week and the patient remains febrile, those cases you have to rethink and consider adding antifungals or changing the class of antifungals after further investigations. So the choice of your antimicrobials will depend on the severity of acute illness, the site of infection, local microbiological data, which is important, and the presence of hepatic and renal function. So usually what is started when a patient comes with septic shock is usually carbapenem with an aminoglycoside. And if patient has risk factors for MRSA, then teicoplanin. And then if there are risk factors for fungal infection, then antifungals like voriconazole or caspofungin. Antivirals in septic shock are not recommended in the initial stages unless you have a documented infection by a SARS-CoV-2 virus or something. Then you have to refer to the specific guidelines and treat accordingly. So after hemodynamic management is over, intravenous antimicrobials we have started. So the third important step is source control. So your hemodynamic resuscitation or antimicrobials are of no use if you don't do a source control. That is, you have to rapidly identify and exclude a specific anatomical diagnosis of infection, which includes abscess drainage, debridement of infected necrotic tissue, removal of potentially infected vascular catheters or stents or implanted devices, CT-guided pigtail insertions or surgical procedures for loculated empymas and perforation, peritonitis, as we discussed in the second case. But while performing all these procedures, thrombocytopenia always comes in the way, and you have to deal with that and then take up the patient for the procedure. So use the least invasive procedure that can effectively achieve source control. So that is what you do in source control. So under source control comes the removal of central venous catheter. So what are the indications for catheter removal or central venous catheter removal? If the patient is in sepsis and septic shock, or the clinical condition of the patient deteriorates, you have to remove it. If there are severe complications such as endocarditis, osteomyelitis, septic thrombosis, or abscess formations, And if Staphylococcus aureus is isolated from blood cultures, then you have to remove. If gram-negative bacilli are isolated from blood cultures, like Stenotrophomonas, Pseudomonas, and Acinetobacter, and Candida species, if these are isolated from blood cultures, you need to remove. There is something called differential time to positivity. That is, you send one blood culture from the possibly infected intravascular device and one from a peripheral puncture. If the differential time to positivity is more than 2 hours, that is, the culture becomes positive at least 2 hours prior in the sample which was taken from the intravascular device, then that means the intravascular device is responsible for the bloodstream infection which is happening in the body. So, but if there are, some catheters in some patients, you cannot remove it due to various reasons. If they are called the highly needed catheters. In such cases, you have the options like the antimicrobial lock technique, antiseptic coated and antibiotic impregnated vascular catheters, and maybe catheter exchange over a guide wire. And that too, if the risk benefit, looking at the risk benefit ratio, if the risk of the benefits of retaining the catheter is more compared to the risks of retaining, then you can go. But otherwise, these are not routinely recommended. So once the causative pathogen and susceptibilities are known, you can de-escalate or go for a targeted antimicrobial therapy, for which you have to daily reassess the patients. A shorter course of antibiotics is always preferred, like 5 to 7 days or max 10 days, not more than that. For this, rapid diagnostic tests, serum procalcitonin and clinical evaluation, these are the things which can help you in stopping antibiotics. Now at 72 hours, if the patient has no fever and no documented infection, then what you can do is you can continue whatever empirical antibiotics you've started till the ANC increases to more than 500. Or another option is, if the ANC recovery is going to happen soon and the patient is clinically stable, you can even consider stopping antibiotics if your cultures are negative and the patient is clinically stable. So how about the use of biomarkers? Procalcitonin is the one which is extensively studied in neutropenic sepsis patients. It actually helps in facilitating the diagnosis of severe bacterial infections, though it's not a gold standard diagnostic tool. It's not a good guide to decide when to initiate antimicrobials, but it can be used along with clinical evaluation to decide when to stop. That is, you can decide what is the duration of your antibiotic treatment. And they've also come up with a new marker called pre-sepsin, which they say is even more specific, but we need more evidence and more research about that. Now, the fourth topic is ventilation. You need to maintain the conservative oxygen targets while ventilating or while using oxygen therapy in these patients, namely a PO2 of 55 to 70 and saturation of 88 to 92. If there is a sepsis-induced hypoxemic respiratory failure, high-flow nasal oxygen is preferred over non-invasive ventilation. And suppose your patient has gone into sepsis-induced ARDS and requires invasive mechanical ventilation, then go with the usual strategies like low tidal volume ventilation, maintain plateau pressures of less than 30. So this is applicable to your ventilation in the operating theater during using the anesthesia machine as well as in the ICU. Higher PEEP is preferred. Traditional alveolar recruitment manuals providing a sustained inflation pressure to recruit more alveoli. If you're using neuromuscular blocking agents along with sedation, then try to use intermittent boluses rather than continuous infusions. Prone ventilation is also recommended in the first 36 hours of intubation. And you can go for a veno-venous ECMO when conventional mechanical ventilation fails and your center has good experience in it. There is insufficient evidence about the use of non-invasive ventilation over invasive mechanical ventilation. So that's about the fourth topic, ventilation. Now we'll go to the additional therapies. What about the role of corticosteroids in septic shock? So it can be used in those patients where there is an ongoing requirement of vasopressor therapy. So it can be initiated when the NORAD or adrenaline dose has crossed 0.25 mics per kg per minute for at least 4 hours. You are unable to taper it despite the use of continued fluid management. The steroid of choice is IV hydrocortisone. The dose is 200 milligram per day. You can either give it as 50 milligram every 6 hours, or you can use it as a continuous infusion over 24 hours. Next is about bicarbonate therapy. This has always been a controversial topic. So in adults with septic shock and hypoperfusion-induced lactic acidemia, the surviving sepsis campaign or the SSC suggests against using soda bicarb to improve the hemodynamics and to reduce vasopressor requirements. However, in adults with septic shock with severe metabolic acidosis of pH less than 7.2 and acute kidney injury, that is, it's acute kidney injury network score of 2 or 3. The acute score of 2 or 3 and severe metabolic acidosis, there the SSC suggests using sodium bicarbonate therapy. You don't have to attain normal pH levels. You can go or you can aim for a pH above 7.2. So that's about bicarbonate therapy. Next is about transfusion of blood products, which is very rampant in an oncology patient. So first we'll talk about the RBC transfusion targets. So in septic patients, they usually say the restrictive transfusion strategy is preferred over the liberal strategy. That is, you wait till the hemoglobin drops to 7. So a transfusion trigger of 7 gram percentage is considered in septic patients. But HB alone should not be your guiding force. You should use HB along with patient's overall clinical status. Like suppose acute myocardial ischemia, severe hypoxemia, acute hemorrhage. These are cases in which you can change your transfusion triggers. Like sometimes it can you can increase your transfusion trigger to around 9 or 10. You can start your transfusion when your HB drops below 10 or 9 gram percentage. So I'll just quickly talk about a few trials. So first trial is called the TRIC trial, which was conducted in 1999, which looked into the transfusion requirements in critically ill patients or the critical care. So that is why it's CC, double C, the TRIC trial. So it compared restrictive versus liberal, that is 7 gram transfusion trigger versus 10 gram per deciliter transfusion trigger. And this they found a similar 30-day mortality. And then came the TRIS trial. They specifically looked into patients with septic shock, double S. So here they compare restrictive versus liberal, that is 7 versus 9. And here they found a similar 90-day mortality. So finally the SSC came up with the transfusion trigger of 7. They said restrictive is more than enough. So then came this trial called the TRICOPE trial. This was published in 2017. So this looked specifically into the transfusion strategy in critically ill oncologic patients, which is more relevant to us. So here 300 adult cancer patients with septic shock were studied, and they looked at the transfusion triggers. It was a retrospective observational study. It was a randomized control trial. They looked into the restrictive and liberal transfusion targets, transfusion triggers in the first 6 hours of ICU admission. And what they found was just opposite the above two trials, that's the TRIC and the TRIS. They found that the 28-day mortality and the 90-day mortality rates were lower in the liberal group compared to the restrictive group, and this is found to be statistically significant. So following that, the SSC guidelines have taken this trial also into account, but still, because of various statistics, they are still recommending a restrictive a transfusion strategy in sepsis patients. But probably in critically oncologic patients, we may probably require more studies to actually decide. But after the TRICOPE trial in our institute, we usually look into, it's a combined decision between the medical oncology and the intensive care team. Usually we keep a transfusion trigger somewhere less than 9 gram per deciliter. So about other blood products will include platelet transfusion and granulocyte transfusion. The trigger for platelets is less than 10,000 per microliter. But if the patient is scheduled for some intervention procedure with a potential risk of bleeding, then you have to decide on an individual patient basis. Granulocyte transfusion is not yet recommended by the surviving sepsis campaign because of the low grade evidence. And also what has been noted is that when you start granulocyte transfusion, most of the patients go into hypoxemia or deterioration of ARDS or even development of nuances ARDS. So at the moment, it's not recommended. Now about venous thromboembolism prophylaxis. It's the pharmacological VT prophylaxis that is recommended unless contraindicated, and low molecular weight heparin is the recommended one compared to unfractionated heparin. But most of our patients would have thrombocytopenia, right? So the SSC used to previously recommend a combination of mechanical and pharmacological prophylaxis in sepsis patients. But while they went through the newer studies, they found that it just resulted in increased costs. There was no difference in mortality or the rates of DVT and pulmonary embolism or in the rates of lower limb ischemia. So now they have recommended a pharmacological VT prophylaxis alone unless contraindicated. But most of our patients, when they have thrombocytopenia, then the option that you have will be mechanical VT prophylaxis in the form of sequential compression devices. Now, about stress ulcer prophylaxis, earlier guidelines mentioned that all patients in septic shock should receive stress ulcer prophylaxis, but the new guidelines suggest that they should be used only in those patients with risk factors for upper GI bleeding, such as shock coagulopathy, chronic liver disease, and those on corticosteroids. This is because they all found a high risk of recurrent Clostridium difficile infections with the use of proton pump inhibitors. And Clostridium difficile infection is very common in neutropenic sepsis patients. So all the more we should be careful in our patient setup while using stress ulcer prophylaxis. And about renal replacement therapy, use either continuous or intermittent renal replacement therapy when you have absolute indications such as uremic complications, refractory acidosis, refractory fluid overload, or hyperkalemia. A mere increase in creatinine or oliguria alone without any of these above absolute indications, RRT is not indicated. Now, regarding whether you should initiate RRT early or late, they found that there has been no difference in mortality whether you start it early or late. And there is insufficient evidence for the use of blood purification techniques like plasma exchange, hemoperfusion, etc. Now, glycemic control, insulin therapy is to be initiated when the glucose level crosses 180 milligram percent, and the target blood glucose range in sepsis patients is 144 to 180. And regarding nutrition, it's always recommended to have an early initiation of enteral nutrition whenever feasible, that is within 72 hours. So in patients with severe septic shock, where the patient is on 2 or 3 inotropes and vasopressors, in such patients, just to keep the gut intact or the gut wall intact, you can give trophic feeds of around 20 to 30 ml every 4th hourly, because if you keep the GI tract idle, then there is a high chance of bacterial translocation into the bloodstream. So to avoid that, you have to give some work for the GI tract. So that is the whole idea of giving trophic feeds. About the use of GCSF, GCSF is a widely used drug in oncology units, but its use is not recommended for routine clinical practice in febrile neutropenia and sepsis patients, because again, just like granulocyte transfusion, there is a chance of ARDS when there is a leukocyte, there is an increase in leukocyte production following GCSF administration. But it can be used in exceptional cases when you are expecting prolonged and profound neutropenia in elderly and in uncontrolled primary disease. Immunoglobulins are also not indicated. And patients should also be given sedation, analgesia, and whole body physiotherapy. You should also go for early weaning with standardized weaning protocols. And the patient should be nursed in a positive pressure isolation room. And also, you should discuss with the families and address the goals of care as early as possible, that is within 72 hours, to determine which treatments or which interventions are required or appropriate and which ones are not decided. And since it's an oncology setup, obviously the palliative care plays an important role. We should be integrating the principles of palliative care also into the treatment plan. Now, what are the problems with the last few slides? What are the problems faced by the onco anesthesiologist? Usually, you get to see these patients when they come with emergency surgery or for interventions. They'll be hemodynamically unstable. You have to deal with that. A poor respiratory status because of pneumonia. Thrombocytopenia, which will have a problem with your regional anesthesia as well as airway bleeding. Mucositis, again, which can lead to airway bleed. Anemia, altered sensorium. It may be difficult to extubate a patient post-surgery because of the altered sensorium. Hepatic and renal dysfunction and various toxicities and adverse effects of chemotherapeutic drugs will come into play. and a postoperative STOMI ICU course. So the clinical pearls would be sepsis and septic shock in neutropenic patients are medical emergencies. Treatment and fluid resuscitation should commence immediately. Fluids, vasopressors, and inotropes can be used to get a mean arterial pressure of 65 millimeters of mercury to maintain organ perfusion. Try to go for dynamic measures to guide fluid resuscitation. Start antimicrobials within 1 hour and source control preferably within 6 to 12 hours. Transfusion of blood products as per the triggers. And high flow nasal oxygen therapy in lung protective ventilation strategies. Hydrocortisone intravenously in refractory shock. Bicarbonate therapy only in selected cases. VT prophylaxis and goals of care and palliative care to be integrated. So thank you very much for patient listening. I know it was an elaborate topic.
Thank you, Dr. Deepa, for an extensive presentation and covering most of the aspects of neutropenic sepsis. And to the attendee, just a few points that when you are talking about neutropenic sepsis, two components is there. One is neutropenia and the challenges related to neutropenia, and is sepsis and sepsis related complications like shock. So for the first part, Dr. Deepa tried to keep it on a simplified form because attendees are mostly students. But if I go to the core critical care regarding the neutropenia, there are a lot of new developments that are happening in terms of the intervention and all. Just to summarize few points, most of the things has been covered by Dr. Deepa, and I will have some queries to ma'am also. So regarding the site of sepsis, as ma'am rightly mentioned, because there is no neutrophil, it is very difficult to identify the site because there is no inflammation. So we have to have a very low threshold, and as ma'am rightly mentioned, the gut can be a very important site like neutropenic enterocolitis or perianal abscess, which very frequently is missed by our clinician while we are practicing. The case ma'am what presented was very challenging, but and again because we do not have enough data for oncocritical care or septic patient dedicated to neutropenia, there are different practice from unit to unit, and we have certain amount of variation when you look at different institutes. Like for in the first case, like in AML, we usually do not use acyclovir prophylaxis in a myeloid malignancy. We use it only in a lymphoid malignancy. Usually, that's our standard practice, and voriconazole is usually given as a mold covering antifungal prophylaxis. So we'll start with that, Dr. Deepa. Can you please elaborate your antifungal prophylaxis policy for neutropenic patients?
For neutropenic patients, usually they start with oral voriconazole in the medical oncology ward. And by the time we get the patient in neutropenic sepsis, the patient will be already on oral voriconazole. And depending upon the clinical scenario, after a discussion with the medical oncology team, we sometimes convert it into intravenous, especially when they have neutropenic enterocolitis and loose stools. And when the oral absorption doesn't happen, we convert it into oral voriconazole. And then later, it is like voriconazole with plus or minus caspofungin, depending upon whether your culture yields some yeast or something like that.
Oh, thank you. Thank you. And just to say, if for in case of solid organ malignancies, usually the neutropenia is short, maybe less than 7 days, and in that situation, probably we do not need an antifungal prophylaxis. In case of hematological malignancy, if we are thinking that probably the candida is the cause, then we usually use fluconazole prophylaxis, and only in AML patient who is induction chemotherapy, in that situation, we usually given mold covering azoles like either a voriconazole, or presently a lot of unit are using posaconazole also because of PKPD benefit. And you can give it that IV with a single day dosing.
Right. Solid organ malignancies, you actually don't require the antiviral and antifungal prophylaxis usually.
True, absolutely. And again, in terms of neutropenia, do you think there is any difference between solid organ malignancy and hematological malignancy in terms of neutropenia?
In terms of neutropenia, I think the severity and the duration is usually less when it comes to solid organ malignancies. It's more severe and more prone for complications in hematological malignancies.
True, because the attendees, please remember that in case of hematological malignancy, the bone marrow is already pathological. So whenever you give a chemotherapy and they get a suppression, even you wait for them, if you give GCSF, their time of recovery is usually very prolonged compared to a solid organ malignancy. Solid organ malignancy, because the bone marrow is normal, they usually resolve very fast with maybe one few shots of GCSF. though it is not very strongly recommended at Dr. Deepa has clearly mentioned. And next, the second case was much more difficult. I know who is your surgeon who has taken a neutropenic colitis patient with a
No,
perfect
I was very
bevacizumab.
particular. That was a case report from a journal. We
Uh,
do not have a patient.
Whoever is
I'll
the
put up the
surgeon
reference below.
is amazing, because I don't think a neutropenic colitis, even if they have perforation, unless there's an active perforation, they usually don't take it. That's the only indication to go in a neutropenic colitis. And also patient who have received bevacizumab, usually the surgical wound healing and the post-op surgical complication is
Right,
so
so the
high.
bleeding will be more.
Surgeon usually take a U-turn when they have bevacizumab. Patient receive bevacizumab, call me after 8 weeks. We're not going to come back. And regarding the definition, you have already mentioned the temperature cutoff, but in immunocompromised patients, certain guidelines or certain definition mentioned even if a single spike of temperature more than 100.4 is significant, and we should take it as a neutropenic fever. And in terms of the antibiotic, you correctly mentioned that in a non-shock patient, in non-oncology, non-neutropenic patient, we can wait for 3 hours, because to cut down the antibiotic pressure in our unit, because rampant antibiotics has been used. But in neutropenic fever, in my unit, usually they give the first dose of antibiotics immediately when they land to the emergency. That's the only exception we practice for neutropenic fever, and after that we evaluate. Now, whether to de-escalate or not, you mentioned yes, there is option to de-escalate when the cultures are negative, but all units are not practicing it. Like pediatrics unit, if the culture is negative, patient is stable, afebrile for 48 hours, they stop antibiotic. Medical oncology, hematology unit, adult patient, even if the patient is afebrile stable, they continue antibiotic till the patient there is a sign of resolution of neutropenia. This is the usual practice. Now we keep on discussing and try to suggest them to come down on the duration of antibiotics, because obviously because the antibiotics too are cheap. You already mentioned regarding the mark score, that is to identify the high risk and low risk patient, but probably I feel that is more applicable in Western countries when there is access to the hospital is very easy. Now in our Western Indian scenario and in Southeast Asian scenario, when hospitals are not that easily accessible, usually sending low risk patients to home is also very challenging. What we usually do, either we admit them to the hospital, keep them for the initial monitoring, you can depend from unit to unit, or we ask them to stay near the tata. So a lot of patients when they are on therapy, specifically kids, they usually remain, they take a rent, stay near hospital, so that even with a very low threshold they can come and get admitted. That's a very standard practice, I think, for
And
our
one more thing about the mass score is that it is more useful while identifying low risk cases. It's not very great in identifying high risk cases. That is what the theory says. But we don't use it in the ICU anyway, because you're already receiving the patient with neutropenic sepsis already.
Absolutely, absolutely. I fully agree on that. And yes, for the attendee, there is a new type of sepsis that you are going to deal with when you are talking about neutropenia. That is, ma'am mentioned, that is a primary BSI or MDI, LCPI. When the gut is the source, because of the chemotherapy, there is extensive mucositis leading to breach in the immune barrier from the gut and the blood, and there are bacterial transmigration that can cause bloodstream infection without any primary source of organ. So that's we call primary BSI, as we could not identify any other source. And ma'am also has mentioned that QSOFA or SOFA should not be used as a screening tool, because if you go to the understanding, SOFA usually identify organ failure. Now, so already the sepsis has been settled in. So they have a good specificity, they have a good prognostic value, for as a screening tool they are not good, because the sensitivity is not that high. That's why the mu score and nu score is much better, and all the recent recommendation is suggesting them to use as a screening tool. But we have as a to rule out, or in terms of prognostication, definitely SOFA is a much better. Ma'am already mentioned regarding the procalcitonin. Yes, procalcitonin can be used to monitor the clinical course, to de-escalate antibody, to rule out sepsis. But the cutoff is little tricky for cancer patients, because it has been shown in cancer patient procalcitonin has a higher level because of the unknown reason, and specifically neutropenic patients. So the cutoff of procalcitonin in a neutropenic septic patients is a little tricky. We usually take one as a cutoff in ICU patients, and if the patients, and you try to follow it up after 48 hours to look at the overall course of the clinic procalcitonin. One one of our doctor has asked regarding the use of FFP for volume resuscitation. What will be your comment, ma'am?
FFPs for volume
Volume
resuscitation is
resuscitation.
that we do not use. It's used only if there is coagulopathy with any bleeding issues. So that's the only indication for
Yes.
the use of FFPs. We do not use it for volume resuscitation as such.
Because a lot of units are using it because the albumin is costly and they try to replace it with an FFP.
Right.
But because it's a human product, the risk of complication related to hypersensitivity reaction is high. Plus, being a blood product, it should not be used so casually. So, most of the critical care unit has been moved away from using FFP routinely. I think very few units are using. Mostly, we use albumin if there is an indication. And as ma'am already mentioned, the role of colloid has been degraded compared to what you used to be.
Right.
So we understand in a sepsis, in a leaky capillary, the ratio is not 1:3 as we conventionally expect in anesthesia during anesthesia. It is 1:1.3. So the amount of fluid, crystalloid and colloid to resuscitate patient is not significantly different. So the indication of albumin has been very limited in while we are resuscitating those patients. Source control, as ma'am already covered, but it is really challenging to remove a Hickman line or a permacath with a platelet of 5,000 or to drain a inflamed source in a neutropenic patient, because rarely they develop abscess, because you will find inflammation, there will be skin and soft tissue infection, but unlikely to be abscess because there is no neutrophil. Removal of the line is very challenging in practical, because platelet is 5,000, 10,000. We are not sure how we are going to remove it. So a lot of time, if the line is the source of infection, what we do, we usually do not use it. We lock it, keep it like that, and try to put another line and use it for the clinical purpose. When the patient is stable, only then we consider to use it. Must be there a difference practice from unit to unit, but that is our practice in Tata. And one doctor has also, yes, ma'am. Okay.
No.
Another question is that regarding the use of ringer lactate when there is a high lactate.
So usually we do not recommend the use of ringer lactate. So nowadays what we go for is balanced salt solutions. The brand names are usually Plasmalite, Capilite, etc., which has acetate also in it. So basically these balanced salt solutions, when you infuse them in large quantities, they are not associated with any metabolic disturbances, unlike saline and RL. So saline, if you use for long periods, you will have hyperchloremic metabolic acidosis. You will start seeing acidosis in the patient, and you will be wondering what is wrong with the patient. At the same time, when you use ringer lactate, especially in septic shock, so usually the lactate in RL gets metabolized by the liver into bicarbonate, and everything goes fine as long as the liver is being perfused. But when you are in septic shock, there is hepatic hyperperfusion as well. So actually, in fact, you're actually worsening the lactate levels. This is my understanding about RL, and probably that is also one of the reasons that RL is not no more recommended. It's always a balanced salt solution, though it's a bit costlier than those. So I think I'm more comfortable using balanced salt solutions.
Yes, I
Dr.
think.
Sudipta, would you like to add?
I think I agree with you to some extent that once you use ringer lactate, you cannot use lactate as a monitoring tool because you are adding to it. But if we look at the data is still not very robust against ringer lactate, even for a patient with septic shock with a high lactate, because people have not explored ringer lactate with balanced salt solution. They have mostly explored normal saline with different balanced salt solution. Ringer lactate probably is the most primitive balanced salt solution we have, with some
Right.
disadvantages, like because it has lactate, so you cannot monitor lactate any further. If there's a liver dysfunction, lactate may go up, and also because it's little hypotonic. So if you're given a very large volume, probably there is some concern, because the osmolarity will be around 130 compared to the body's osmolarity, which is 145 to 155. So that can be little concerning when you are using ringer lactate. But in a resource limited setting, I think we can still consider using ringer lactate if other things are not balanced salt solutions are not available. Yes, GCSF you have already mentioned, ma'am, that it is not very strongly recommended. Studies have shown that there is no mortality benefit if you add GCSF in a neutropenic patient. Only the resolution of neutropenia is faster. But whether that eventually help in a clinical outcome, because all those neutrophils are premature neutrophil, they are not functionally active, they do not have the capacity to do oxygen burst. So whether they're helping us, the patient, in terms of resolution of sepsis, we are not aware. Solid organ cancer patients, when they develop neutropenia, they have a very low threshold to add GCSF. For hematology, what they do, they first rule out the bone marrow that yes, there is no active disease in the bone marrow, and after that they usually add GCSF. It's also varies from patient to patient. Buffycoat and granulocyte also you have mentioned that yes, there are risk, no definitive indication, but in some situation in a non-pulmonology infection, specifically skin soft tissue infection, we are using Buffycoat with a good success. One of our colleagues, one hematology colleagues, has also presented the data also in an international forum. It shows that it has a good prophylactic role. Patient is neutropenic, you are giving Buffycoat as a prophylaxis, it is very good. But if the patient has a lung disease, you give Buffy or GCS granulocyte, it goes to the lung and can significantly worsen the lung function. When I joined, initially we used to use Buffy in all patients, then gradually from our mistake we have learned and stop using it totally in case of lung pathology. Lung pneumonia we do not use at all. Antifungal prophylaxis we have discussed. Antiviral prophylaxis again, preferably if we can give vaccination to this patient preemptively, better. Ma'am, we will take another 2-3 minutes. Is that okay?
Yes, yes.
So for antiviral, I think better to give vaccinations. We cannot give live attenuated vaccine. We try to give killed vaccination in neutropenic patients, or we are waiting for chemotherapy. Better to take it 2 weeks before or 2 weeks after the chemotherapy. There is a certain time period which we usually avoid for giving vaccinations. That is the idea. And for antiviral, again, we give them for a T lymphocyte abnormality like an ALL or some T cell lymphoma. In that situation, we usually give antiviral prophylaxis. And in severe case, patient may need further workup for CMV and all those things, EBV and all those things. And I think by this we have covered most of the things. Another is regarding the NIV. I fully agree that present recommendation, if you go by the previous recommendation, they show NIV is a grade 1 recommendation for immunocompromised post-transplant patients for hypoxic respiratory failure. But with time, because the critical care has evolved significantly, presently lot of neutropenic patients, cancer patients, in post-transplant patients who have got intubated, they usually come out. They are doing much better compared to 10 years, 15 years, 20 years before data. And it has been proved that it is better to intubate them early rather than stretch it to the extreme level and then intubate. So probably the practice is changing, and in coming years we'll have more robust data in terms of intubation and invasive respiratory support in neutropenic patients. Still, the standard teaching is that this is a grade 1 recommendation for NIV if the patient is immunocompromised and post-transplant. And yes, I think we have covered just few questions from the attendee. One doctor has asked your experience of using albumin as a volume expansion. So what percentage volume and rate of administration?
So I think theoretically they say to use 5% albumin, but what is available with us is only 20% human albumin. So we use that 20% human albumin. And while infusing, usually we use it only when we realize that the crystalloids are becoming too much. We are infusing lots and probably the lung is getting met. In such scenarios, we use that 20% human albumin. And while we are transfusing 20% human albumin, we reduce the rate of flow of the IV fluids which we were infusing. Like suppose it was going at 100 to 150 ml per hour, then we would reduce it to some 50 ml per hour. And albumin is usually given, the 20% albumin is given as a slow infusion over 4 to 5 hours. That is around 20 to 25 ml per hour, and usually a single dose or maybe twice daily. The problem is mainly the cost factor of 20% human albumin.
Yes, we presently have 5% albumin, but we compare the total amount of the weight of the albumin, 5% is way costlier. So even with it is available, still we are using 20%. And as you rightly mentioned, we use it after the initial fluid resuscitation when the volume of fluid required to resuscitate the patient is very, very high. There is very limited data for the attendee. It was some what are the subgroup analysis of the VAST trial, which are shown that in a septic shock with a low albumin, we should use it. But overall, after that, there is no RCT. But some meta-analysis has shown if you add albumin in the part of resuscitation in septic shock, probably those patients do better. Even there is a small advantage in terms of mortality. But there is no head-to-head RCT which shows that albumin is better compared to crystalloid when you are causing the resuscitation. I think we have covered most of the part of the presentation. I try to address all the questions that has been put to the box.
I think one last question. Can the use of GCSF in neutropenia cause tachycardia? Honestly, I've not noticed because most of the patients come with tachycardia. I'm not sure whether that increases.
It can cause tachycardia because of worsening in the inflammation. Because there are times when you give GCSF, we mobilize neutrophils, and it can go to the site of infection, and the inflammation can worsen. The same thing happens. It's something like a reconstitution syndrome that happens when there is a resolution of neutropenia. Whenever there is a normal resolution of neutropenia, your site of sepsis will worsen. If it is a lung, then you are unlucky. Patient will develop an ARDS. It's a soft tissue. Probably you are just okay. Kidney is okay. Bowel, it's okay. Bowel improves rapidly. Enterocolitis improved dramatically once the WC comes back. But lung will give you a bad hit. It will go into worsening shock, hypoxemia. Patient may develop an ARDS, and all kind of stuff can happen. So in that aspect, because of worsening inflammation, patient may develop tachycardia.
Otherwise, there is no direct, I feel.
I'm not aware. Direct, I'm also not aware. I think we have covered most of the topics. Any comments, ma'am?
Deepa and Sudipta, both of you, I just want to know, is there any recent data about the cutoff marks? Suppose this patient neutropenia, not neutropenic sepsis, but patient with neutropenia, they come for any small procedure like Hickman catheter insertion or some procedure. Is there any cutoff value from that? We can say that this patient now we can take it and this value, or we can postpone and take later after some value is the normal value. So is there any cutoff mark? Recent data is there?
Ma'am, for any procedure like vascular catheter insertion or something?
Yeah, for in neutropenia, patient with neutropenia.
Ma'am, as far as I know, I don't think there is any cutoff, but definitely you will be doing it under strict aseptic precautions. So probably I think because most of the time neutropenia is not just post chemotherapy, it's part of the disease progress, and the patient is coming to you for a catheter insertion so that they can be administered chemotherapy. So I think if you keep a cutoff, I think it's going to be bad for the patient. You'll be merely postponing it. Sudipta, maybe, I don't know what is your practice.
Usually we do not, I am not aware of any definitive cutoff, but in neutropenia, if you go for a major surgery, obviously the complication rates are higher, and it's better to avoid any planned surgery. But obviously, as Dr. Deepa also mentioned, there are cases like a emergency surgery or semi-emergency surgery that you have to take it. Like we did a obstructive bowel obstruction last week with a WC count of 100. Patient has a reasonable recovery and extubated and reasonably stable on antibiotics. But these are emergency surgeries you cannot delay.
For elective procedures, suppose in case of we find it very often in case of Hickman catheter, Hickman insertion, where the patient needs that Hickman.
Hickman have to do it because they are going to receive chemotherapy, and after that,
that's right. They need the line for the treatment, so we cannot wait for those patients.
That cannot be.
Even if there is actually, I think literature says that in severe neutropenia or in case of pancytopenia, we should wait till it comes little balanced value. But in case of this patient, when it comes for Hickman line insertion, that is necessary for the treatment. So we cannot wait for that thing. So we need to take the patient.
The problem is that once they receive chemotherapy and platelet drops, putting lines is very, very challenging. They keep on bleeding. So mostly whenever the primary team is planning intense chemotherapy, which anticipate a prolonged neutropenia, prolonged thrombocytopenia, they usually go for a definitive line. They either put a PIC, solid organ malignancy patients, usually they have a smaller neutropenia and thrombocytopenia, they put a double lumen PIC. Hematological patient either put a Hickman or Palmer depending on their practice. But they try to have a definitive line so that you can send investigation regularly from that line. You don't need to puncture the patient on a regular basis. And the clinical course is much under control. Getting a stable vascular access is very, very important while managing critically ill patients.
Yes. There is another question, I think, now.
Yes, that I can take all. That Dr. Deepa, you would like to make any comment? Probiotic while on neutropenic sepsis?
We do not use it. We do not use it.
We do not use it, right? Absolutely correct, because in an immunocompromised patient, they may cause infection, probiotics. So it is one of the standard contraindication for using probiotics. There are case report which shows that patient develop disseminated infection with lactobacillus. So it is absolute contraindication, but yes, you can use prebiotics. prebiotics is not the bacteria but the food modification like curds and all those things that can be used, but you should not use probiotics. That's absolute contraindication.
So,
Any
more
comment from
question?
any comment from any other panelist? Ma'am, any comment from your side?
I don't think any other question or comments.
So, I think. Do you think
we can, I think, call it a day. It's already 7:50, and it was a nice discussion, very nice discussion, interactive discussion. And it's actually every onco anesthesiologist should know this topic, because we get many patients with neutropenia, neutropenic sepsis for anesthesia purpose also, and also for critical care treatment management. So thank you very much, Deepa and Sudipta, both of you discussed very well. Very well. It was very informative and very interactive. Thank you very much. I think
thank you, madam, for
we are ending the session today.
I think it was too elaborate, the topic, even after cutting short antibiotics to just 2 slides.
But it is very useful discussion. Very useful discussion, and every one of us should know about the details of the things.
Absolutely.
Thank you very much. Thank you.
Thank
you so much to everyone. And with all your permission, I'm closing the session here for today and looking forward to hosting you again. Thank you so much.
Thank you.
Thank you.
Thank you.
Thank
Good night,
you.
everybody.
Good night.
Good night.
Good night.